Chronic obstructive pulmonary disease, COPD. The basics. Definition, pathophysiology, and risk factors. 1. Definition. Persistent airflow. Limitation. Chronic and progressive. COPD is a chronic and progressive respiratory disease characterized by persistent airflow limitation. Not fully reversible. The airflow obstruction in COPD is typically not fully reversible with medications or other treatments. Airflow limitation. This limitation is usually caused by a combination of inflammation, airway narrowing, and loss of lung elasticity. Emphysema and chronic bronchitis. COPD encompasses two main pathological entities, emphysema and chronic bronchitis, that often coexist to varying degrees. Note: it is important to know that COPD is a very common and potentially debilitating disease. 2. Pathophysiology. The mechanisms of airflow, obstruction. Chronic inflammation. Primary cause. Chronic exposure to inhaled irritants, primarily cigarette smoke, leads to persistent inflammation in the airways and lung tissue. Inflammatory cells. Activation of inflammatory cells such as neutrophils, macrophages, and lymphocytes that cause tissue damage. Note: inflammation is a major driving force behind the disease progression. Airway remodeling, small airway narrowing. Inflammation and scarring lead to narrowing of the small airways. Bronchoconstriction, increased muscle tone of the airways that can be episodic and reversible with medications. Increased mucus production, causes chronic cough and sputum production. Alveolar destruction, emphysema, destruction of the alveolar walls, air sacs, with loss of lung elasticity. Air trapping. This results in air trapping and hyperinflation of the lungs. Note: reduced surface area for gas exchange. Mucus hypersecretion. Chronic bronchitis. Chronic inflammation of the bronchi leads to increased mucus production and chronic cough. Note: overlap with emphysema can occur. Loss of elastic recoil. Damage to the alveoli and surrounding lung tissue reduces the elastic recoil of the lungs, leading to airflow limitation and air trapping. Note: the pathophysiology is complex with overlapping components that usually leads to irreversible damage. 3. Risk factors. Identifying the vulnerable patient. Smoking. Primary risk factor. Cigarette smoking is responsible for the vast majority of COPD cases. Dose-response relationship. The risk increases with the duration and intensity of smoking. Note: pack year history is a useful tool to determine a patient's smoking history and risk for COPD. Note: even secondhand smoke is a risk factor for developing COPD. Age. COPD becomes more common with increasing age. Occupational exposures. Dusts and chemicals. Prolonged exposure to workplace dusts, fumes, and chemicals. Note: common causes of non-smoking related COPD. Air pollution. Long-term exposure to indoor or outdoor air pollution. Genetic predisposition. Alpha-1 antitrypsin deficiency. Note: rare genetic cause of COPD that can lead to severe and early onset COPD. Childhood respiratory infections can affect lung development and increase susceptibility to COPD in adulthood. Note: exposure to irritants is the most important risk factor to understand and should be targeted for prevention. Clinical manifestations and diagnosis. Recognizing and investigating COPD. 1. Clinical manifestations. Recognizing the signs and symptoms. Dyspnea, shortness of breath, the hallmark symptom of COPD that is persistent and progressive, and that is usually worse with exertion. Chronic cough. Productive cough that may be present for several months of the year, that often worsens in the morning. Sputum production, chronic mucus production. Wheezing can be present especially during exacerbations. Chest tightness, a sensation of chest restriction. Fatigue, due to the increased work of breathing. Weight loss can be due to increased energy expenditure. Decreased exercise tolerance, limitation in physical activity due to dyspnea. Advanced COPD, pursed lip breathing to help prevent air trapping. Use of accessory muscles indicates severe respiratory compromise. Cyanosis, bluish discoloration of skin or mucous membranes due to hypoxemia. Pulmonary hypertension, increased pressure in the pulmonary arteries. Right-sided heart failure, cor pulmonale, edema, jugular venous distension, and hepatomegaly. Note: the clinical presentation can vary widely depending on the severity of the disease and its components. Note: it is important to note that many patients may have symptoms for many years prior to diagnosis. 2. Diagnostic workup, a step-by-step approach. History and physical examination, detailed history of symptoms, risk factors, and a thorough examination including lung auscultation and looking for signs of cyanosis, edema, or other complications. Spirometry, the key test for diagnosis. Forced expiratory volume in 1 second, FEV1. Amount of air that can be forcefully exhaled in 1 second. Forced vital capacity, FVC. The total amount of air that can be forcefully exhaled. FEV1/FVC ratio. The ratio of FEV1 to FVC is reduced in obstructive diseases. Note, post-bronchodilator FEV1/FVC ratio of less than 0.7 or 70% confirms the presence of airflow obstruction consistent with COPD. Note, spirometry is essential for confirming the diagnosis and assessing the severity of COPD. Post-bronchodilator testing. Spirometry is repeated after administration of a short-acting bronchodilator to assess for reversibility of obstruction. Note, reversibility is very limited with COPD. Imaging studies. Chest X-ray, useful to evaluate for hyperinflation, bullae, or other underlying lung abnormalities. Note, can also rule out other conditions. Computed tomography, CT. Scan of the chest, more detailed evaluation, and useful in patients with severe disease or with suspected complications. Arterial blood gas, ABG, may be done to evaluate for hypoxemia or hypercapnia. Alpha-1 antitrypsin testing. If there is a high clinical suspicion for AAT deficiency, such as in a young patient or family history. Note, diagnosis requires both clinical evaluation and spirometric confirmation. Management. Strategies for treating COPD. 1. Smoking cessation. Essential. The single most effective intervention to slow disease progression. Counseling and support. A combination of counseling and pharmacotherapy, including nicotine replacement, bupropion, and varenicline, can help. Note, this is the most important step to prevent further progression. 2. Pharmacotherapy. Reducing symptoms and exacerbations. Bronchodilators. Beta-2. Agonists. Short-acting, for example, albuterol, and long-acting, for example, salmeterol, formoterol, to dilate the airways and relieve bronchospasm. Anticholinergics, short-acting, for example, ipratropium, and long-acting, for example, tiotropium, to block muscarinic receptors, causing bronchodilation and reduce mucus production. Note, these medications are the cornerstone of COPD management. Inhaled corticosteroids, ICS. Mechanism. Reduce inflammation in the airways but have a limited effect on mortality. Note, used in combination with a long-acting bronchodilator in patients with persistent symptoms and history of frequent exacerbations. Combination inhalers contain a long-acting beta-2 agonist, LABA, and an inhaled corticosteroid, ICS, or a long-acting muscarinic antagonist, LAMA, phosphodiesterase 4, PDE4, inhibitor. Mechanism. Roflumilast, a PDE4 inhibitor, reduces inflammation and mucus production. Note, used in a subgroup of patients with chronic bronchitis and frequent exacerbations. Mucolytics. Mechanism, help to thin and loosen mucus. Note, limited evidence of benefit. Antibiotics, used in COPD exacerbations that are due to bacterial infections. 3. Oxygen therapy. Supplemental oxygen given to patients with hypoxemia. Note, shown to improve survival in patients with severe hypoxemia. 4. Pulmonary rehabilitation. Exercise training, supervised exercise programs to improve exercise tolerance and quality of life. Education to manage dyspnea and improve inhaler technique. Note, improve function, reduce hospitalizations, and improve overall quality of life. 5. Management of exacerbations, short-acting bronchodilators, as needed. Corticosteroids, oral or intravenous corticosteroids. Antibiotics, if there is evidence of a bacterial infection. Supplemental oxygen, if hypoxemic. Note, treatment is focused on reversing symptoms and preventing complications. Long-term considerations, the big picture. 1. Monitoring for exacerbations, frequent monitoring of symptoms and lung function and exacerbations. 2. Management of complications, treatment of comorbidities, respiratory failure, pulmonary hypertension, and right-sided heart failure. 3. Vaccinations, annual influenza vaccine and pneumococcal vaccine to prevent respiratory infections. 4. Patient education, educating patients on self-management strategies and to recognize signs of exacerbations. 5. Psychosocial support, addressing the emotional and social challenges of living with a chronic disease. Key takeaways for exam success and future practice. 1. COPD is defined by persistent airflow limitation and is a combination of emphysema and chronic bronchitis. 2. Smoking is the primary risk factor for COPD. 3. Spirometry with post-bronchodilator testing is essential to make the diagnosis. 4. Understand the different treatment options, including smoking cessation, bronchodilators, inhaled corticosteroids, oxygen therapy, and pulmonary rehabilitation. 5. Recognize that there are non-reversible structural changes in the airways and lungs. 6. Long-term management is essential to prevent further exacerbations.